Hi everyone. So in keeping with our virtual meetings, we're going to stick with our normal meeting structure. So we're going to be doing these safety minutes and gear minutes, as you'll see. This week's safety minute will probably be a little longer than a minute. We're going to go over the SOGs for COVID-19 response, particularly for medical calls. This was prepared by Tom last week. This was pushed out to medical personnel in town. I believe some firefighters got it too that usually respond to medical calls, but it's mostly just concerned with medical response to calls that have the potential for exposure to COVID-19. To start this off, I want to talk about the U21 codes. So when a call is placed to the RCC, when a 911 call is placed to PSAP, the Public Safety Answering Point, when they receive a call, they start asking a series of screening questions. Questions like, do you have a fever? Have you had a fever? Have you been coughing recently? Have you been in contact with anyone that's considered positive for COVID-19? They ask a series of questions and then they determine how to classify this call. If they believe that there is a inherent danger for responders, an exposure for responders going to this call, they'll classify the call as positive U21. So positive U21 just means that the patient answered yes to some of those questions. It means that they might have had a fever recently, they could be coughing recently, they might have signs of a lower respiratory infection or a fever. Now, this does not necessarily mean that they definitely have coronavirus. This question was brought up at a call last week. It doesn't mean that they stuck a Q-tip in their nose and they tested positive for corona. This just means that, COVID. This just means that they answered yes to some of those questions. Negative U21 means that they answered no to these questions, that based on the information that the dispatch has received, they don't think that there is any kind of risk of exposure for personnel going to the scene. The third is inconclusive U21. This just means that the RCC does not have enough information to determine if there's an exposure risk or not. So inconclusive U21, these calls are going to be treated as a positive U21. When we get toned out, you'll hear the RCC say, however many-year-old male at whatever such and such address, they'll report the complaint and then they'll say positive U21. This patient is positive U21. This patient's negative U21. If sometimes they might have more information that they're not going to give over the radio. Sometimes they'll indicate, they might say like 1021, give us a phone call, or just they might even say like please call the RCC. I've heard that a couple times. Them just them wanting to inform us more give us more information that they can't necessarily give over the radio. Again, these U21 codes, it doesn't mean they've been tested positive. It's just a screening system for the RCC. Now, for a medical response, when you arrive on scene, if rescue's not already there, stage outside. All our PPE that we're required to have is on rescue. So anything that we need to wear for a positive or an inconclusive U21 patient, it's all on rescue. So just wait outside, wait for rescue to come, and then we can make a response based on the information that we have once we're on scene. If you're there, you can make contact with the patient or the caller, whatever it was, through a window, through a door, but make sure you're wearing PPE. Wear a surgical mask and wear gloves as they're available. Right now we have plenty of both. So wear a surgical mask and wear gloves. Go knock on the door, and it doesn't hurt to just say, hey, look, we're not looking at coming in right now. I just got to ask you a couple more questions before we come in. And just make sure to keep in mind the social distancing. 6 feet away. You don't have to touch your doorknob. Just knock on it, let them open it up. And you can ask them these supplemental questions. Now, these questions are mostly the same as what the RCC's already asked them, but once we get on scene, there might be more information that's available to us as the responding agency that the RCC didn't have available to them. So by asking these supplemental questions, We're just gathering as much information as possible to make a decision on how we're going, or how, if at all, we're going to treat this call, we're going to treat the patient. So the 3 screening questions that we need to ask when we arrive on scene through the door, through the window, during the initial interview process here, initial response. Number 1 is, does the patient have, or has the patient recently had, any signs of a lower respiratory infection, such as cough or shortness of breath? Number 2 is, does the person have a fever, or have they had fever-like symptoms in the past few days? Fever-like symptoms include chills and rigors. Number 3, does anyone else in the house have any of these symptoms? Now, something that's important to note, before this kind of blew up, one of the questions that we asked and the RCC would ask is, have you traveled outside of the country, outside of the state, anything like that? We're now in the community spread of the disease of COVID-19. So for them to be treated as a positive U21 patient, they don't have to tell us that they were in a wet market in Wuhan eating bat meat. Just because they didn't travel outside of the country does not mean that they weren't exposed. Now that it's in the community spread, there is a potential for exposure anytime you go to the grocery store, anytime you go to the gas station. So we're not really concerned with their history of travel. We're more concerned of the symptoms that the patient is currently or had previously presented, because that gives us the information that we need. It's good to know if they were eating bat meat at a wet market in Wuhan, because that's pretty important stuff. But if they haven't traveled outside of the country or the state or even outside of their home, that doesn't mean that they're not at risk to expose us. So we're more worried about the symptoms they're presenting or they have been presenting recently. While you're talking through the door, through the window, whatever it is, to the patient or the caller, some other questions, we want to figure out how stable the patient is. Asking if they're breathing well, if they're breathing normally, or if they're having trouble breathing. If they're confused or are they alert and oriented. Do they have an altered mental status from their baseline? Again, if Mima is usually a little crazy and she's acting a little crazy now, that's not too different from her baseline. These questions just, and there might be other questions depending on the circumstance. These just help us decide if it's immediate and we need to send personnel in. As a non-transporting service, this is recommendations from Maine CDC and Maine EMS. As a non-transporting service, if it's a non-immediate call and they don't require immediate medical intervention from our personnel, we do not need to enter the building or make contact with a patient if we don't have to. So if it's a call for 2 a.m. toe pain, their toe's been hurting for the past couple of days and they're looking for a ride to the hospital, we don't need to get in there and get 2 sets of vitals to hand to the ambulance when they get here. We can stage outside and we just need to continuously monitor their condition through the conversation, through the door, just like we made original contact with them. But, so we're not going outside to sit in the truck and wait for the ambulance. We're continuing to assess them from a distance. But if we do this, we're limiting exposure for our personnel and we're limiting the use of PPE. If we don't have to go in and suit up and wear all our PPE, then that frees up more PPE in the future for other calls. And again, we're limiting the exposure for our personnel. If the conversation at the door we figure out that it warrants a response for our personnel to go in, then we're going to send one EMT in initially. And they can make an assessment. If they need additional personnel to help them, then we'll send them in one at a time. But the name of the game here is limiting exposure. We want to expose as little people as possible and as little equipment as possible. There's a list that Tom's developed here, and he's even noted it's an incomplete list. It's basically a list of complaints that they might report to us that are going to warrant immediate intervention from us. That no matter what, we're going to have to send someone inside to assess the patient. So any calls involving chest pain, anything that has to do with shortness of breath or not breathing, syncope, near syncope or unconsciousness, uncontrolled bleeding, head trauma, altered mental status, childbirth, stroke-like symptoms. Again, that's not a complete list. Use your judgment. If there's something that's not on that list that, as a medical personnel, you feel as though that warrants a response, use your judgment. Make a good informed decision with everybody there. Make a collective decision if we have to send people in. So if you're sending personnel in, again, one at a time, if we're sending personnel in, they have to be wearing full PPE. This PPE includes an N95 mask. It includes eye protection, so that could be goggles or a face shield or glasses if need be, safety glasses, an isolation gown, and a double set of gloves. In addition to the PPE, only take in the equipment that's required for the call. So if we're talking about altered mental status on a diabetic patient, we're going to need the glucometer and probably the oral glucose, but we don't need to take the whole jump bag and the drug bag in, because that's exposing the majority of our equipment when we really don't need all that. So if it's a call like that, consider just taking the glucometer and the oral gel out of the drug bag and going in with that initially. If you need more equipment, then call for it and they'll bring it in. But the initial response, we need to bring in as little equipment as possible, because at the end of the call, we have to decontaminate everything anyways. So it saves everyone the headache of having to dump out the whole jump bag and spray that thing down and disinfect it and decontaminate it if we really didn't use anything out of it besides, for example, the glucometer. The other thing, if the ambulance gets here and they have adequate manpower, the two of them that came on the rig can move the patient themselves, then we do not need to be involved in moving the patient. If they request a lift assist, if they need help moving the patient, then we'll absolutely help. But any personnel that are involved in that need to be in full PPE. Per our SOGs, if you're within 6 feet of the patient that's inconclusive or positive U21, you need to be in full PPE. As I stated earlier, the N95 mask, eye protection, isolation, God, I can't talk. Isolation gown and double gloves. So if you're within 6 feet of the patient, you need to be wearing that. All your PPE that you're wearing, it needs to be disposed of in a red biohazard bag, tie it off and put it in the back of the rig. The ambulance, when they get to the hospital, they'll dispose of that when they dispose of the rest of their PPE. They'll take care of that for us. That way we don't have to worry about disposing that on our own. They'll take care of that. They'll take it to the hospital for us. This is the part of the SOGs that Tom is going to be editing here in the next couple days. Within the next couple days, you'll get an email from him, and it's going to be an updated version, an edited version of the SOG here regarding N95 masks. So I'm not going to talk about that. This states that N95s can be reused, and as you'll see with Tom's update, that's not really the case anymore. But I'll save that for later. I'll save that for Tom's update, and he'll be able to fill us in on that. So basically, in general, the name of the game, like I said, is limiting exposure for our equipment and our personnel, and just keeping everyone safe. If we get sick, if we come down with whatever, we can't respond to emergencies in town. So we need to keep as little people exposed as possible and as little equipment exposed as possible. If you're not feeling okay, if you're feeling sick, don't come to calls. If you think it might be a cold, at best, it might be a cold. But with a cold comes a weakened immune system. If you're coming to a call, you could be passing that off to other providers. You could be passing that off to a patient. And the other thing, if you have an already weakened immune system from a cold that you might be fighting, we don't know what we're exposing ourselves to when we're going into people's houses. Like I said, we're in the community spread of this disease. They can be picking it up from anywhere, and we can be picking it up from anywhere. If you're not feeling okay, stay home. There's plenty of people in town at this point that can respond. There's a sufficient amount of medical personnel that can respond, especially if we're just sending one person in. We have adequate manpower. Stay home if you're sick. The other thing is it's a good idea to keep track of your temperatures. All the medical personnel that are active responders in town right now we have a big collective spreadsheet, and we're taking our temperature in the morning and taking our temperature at night. And we're recording that in a spreadsheet just to develop a baseline for our records. If you're not already doing that, if you're non-medical personnel and you're not already doing that, consider doing it. If you have a thermometer at home, consider doing that and keeping track for yourself so you can figure out what your baseline is over a period of time. That way, if you think you start to come down with something after coming into contact with a patient or coming into contact with anything really, you can look back at your baseline and figure out what's normal for you and figure out if you are developing a fever. At the end of the day, like I said, let's just keep everyone safe, stay safe, make healthy choices, and don't lick any doorknobs. Moving forward, we're going to try to keep doing these virtual safety minutes every Tuesday. If this is deemed, if this isn't the best way to do this, then we'll make corrections. If there's a better platform for these safety minutes, if there's a more attractive person that wants to sit in front of the camera, and tag me out, that's totally fine. We're just going to see what works best moving forward. That way we can stay in communication with each other virtually, and we'll be able to keep everyone informed and be able to kind of hold our traditional Tuesday meetings in a non-traditional format. So thank you very much. Feedback is absolutely encouraged, and have a good day.